All right, so exam one. So where do you want to start? What do you want to know? You know the 4 topics, right? What are the 4 topics? So you got EKG, ABG, diabetes, and central lines, right? So the ratio is going to be heavy on diabetes and EKG. I think it was like 26 diabetes, 25 EKG, or 24 maybe. I can give you the exact numbers, but those are the biggest ratio. And then ABG is like 20-ish, and then lines are like 10-ish. Okay, so that's kind of the weight of the exam. But all the exam questions all interrelate. So if you have a diabetes question, it's going to have options that are from ABG and from diabetes and lines and whatever, an EKG, right? Or there might be an EKG strip and it asks you for a diabetic complication, right? Or it has a ABG question has an EKG strip in it, and you have complications there. All right, why would you have an EKG strip in ABG land? What could cause EKG changes ABG wise? Hyperkalemia can do it, right? You can do a little strip of hyperkalemia. What does hyperkalemia look like? Peaked T waves, right? All right, so if you haven't ever seen an EKG strip with peaked T waves, so hyperkalemia, EKG. All right, I think there's some on the slides as well, right? I should probably just pull up the slides, right? So you got peak T waves, where we're at here, all right? Until it signs off. Yep, it's got some peak T waves and everything widens out. Okay, that's a probably good one. Everything widens out, right? PR gets wide, the QT gets wide, the QRS gets wide until it just looks like a sine wave. It looks like a tide, all right? And then it goes into asystole, all right? So yeah, hyperkalemia. What else can ABGs lead to EKG problems? You guys all found the exam one? I was working on it yesterday and I had like 15 viewers, right? You guys know where the exam one study guide is? It's the exam one study tools, right? Do you know where that is? So to make sure everybody's on the same page. And I was like, oh, I never saw that, right? It's on the exam one study tools in the Google Drive, right? The lecture folder. So metabolic alkalosis doesn't have too many symptoms. It's very, very benign. But I mean, yes, it can cause you to get really, really sick if it's really, really severe. But really, we're thinking acidosis. Acidosis could cause some EKG changes. What would acidosis cause besides hyperkalemia? You have a low pH. What does that do? Triggers an SNS response, right? And what does SNS response do? Tachycardia. What is an EKG? That's tachycardic. Sinus tachycardia, right? So yeah, so you got a sinus tachycardia. Which one of these ABGs might cause it? The one that has acidosis, right? Right. Alkalosis. I didn't really give you much for alkalosis, and it's really very benign. I mean, you just treat the underlying cause, and those are your symptoms, right? What are your symptoms of metabolic alkalosis? So like, and the causes kind of bleed over into symptoms. So what are your causes of metabolic alkalosis? I think I heard it. Vomiting. All right. So yeah, so vomiting is going to be, that's a symptom, right? It's like, oh, you might be at risk for metabolic alkalosis. So let's look into that. Let's give you what? Acetazolamide is usually for diuretic use, right? But if they're vomiting, you're going to give them what medication?
Antiemetic.
Antiemetics, right? And antiemetics, you got to look out for what? QT prolongation, right? So there's all kinds of interconnections, right? So I apologize. Is this where you wanted to go with ABGs and such, or do you want to? Is there a certain topic you want to look at? Is your time, right? It's my time, but it's your time too. All right. So yeah. So you want to integrate the concepts too. Yeah. So that's kind of how you want to study it. Try to connect all the concepts. Oh shoot, we talked about that over in lines. Lines had CLABSIs, and CLABSIs have infections, and infections have SNS response, and SNS response has sinus tachycardia. Shoot, right? So you got to make the concepts right. Because in real life, they're not going to say, the patient's not going to come in. It's like, I think you got a CLABSI, right? You check me out. Or put me on the EKG monitor, please, right? They're not. They might Google that, but that's not really Googleable, if that's a word. Okay. All right. So yeah. So you want to make sure you are understanding what the words mean. Okay. So if it says they have acidosis, that should spark like a Pixar moment, like a ratatouille moment where you see your childhood, and it's going to be, like, oh shoot, that's sinus tachycardia, or that's, any tachycardia can cause any SS response can cause any tachyarrhythmia, right? And if it's severe enough acidosis, what happens? It's like severe acidosis before death.
I cannot.
VTAC, right? A lethal rhythm, right? So they get a lethal rhythm. You get your H's and T's. Which one of your H's and T's is acidosis? Hydrogen ion excess, right? So those aren't just 8 things for you to memorize or 10 things you memorize. They mean something, right? So I got to connect. Oh, that ABG is super bad. That maybe they have that puts them at risk for a lethal rhythm, right? All right. What else? Where do you want to go? We look at EKGs, all right? So I kind of put a lot of different, this is what, 10 pages? Whoops, what happened here? All right, so it's like 10, 12 pages of just kind of recapping important concepts, right? So again, lecture is all about theory and why and the reason behind each one of these concepts. So it's not, you're not responsible for every single pathophysiology and hyperpolarization, depolarization, or anything. You're supposed to just know what are you supposed to know out of lecture? Supposed to know the causes, right? The symptoms, the treatment, complications. If they don't take the treatment, then these are the complications, like diabetes. They don't keep the diabetes under control, then the complications are many. There's a lot of complications, right? And that could be a whole table in of itself of just the complications, right? And then you have what's the last thing? Whatever was miscellaneous, which is like your interventions and teaching, right? So what are you going to teach them to, that's specific, like insulin injections, or if it's like a central line stuff. Okay, so yeah, like eclampsia is a disease, not so much a disease process, but it's a problem. And what are the causes? Is you can have 2 things. A, you're not fixing the outside milieu, outside environment, right? You're not doing the dressing changes. You're not doing chlorhexidine baths. You're not doing, I don't know. I can't think of something else, but I have it here. Or and then you're not doing the inside lumen stuff, intraluminal versus extraluminal, right? So intraluminal will be what? What are you not doing to the lumen? That might put you at risk for eclampsia. Port cleaning, right? Hand washing, right? Hand washing kind of applies to both, right? If you can just touch the outside of it with a dirty hand, that's not gonna help. But if you touch the outside of the ports with a dirty hand, that's not good either. Okay, and then what else? So that sterile dressing is kind of more extraluminal. That's I mean, this is all ingrained, right? And someone's not going to drill you and say, oh, that's, are you doing extraluminal or intraluminal care right now, right? But intraluminal is just like ongoing care that we have to do, right? So what does that ongoing care include besides ports? Yeah, tubing. Tubing's a good one, right? So you got different tubings out there, right? You got TPN, right? And that should fire some red flag, or not red flags, but some brain activity. So you say, oh, it got TPN. That could be what? It could be a vesicant, right? Right, because it has what in it? Has D what? D20, right? Yeah, D10 plus, sometimes D15, but usually can be all the way to D40, right? So that's why it's given how? Via central line. It's high risk for infection, right? So that being said, with TPN, how do you give TPN, or what's the tubing change on TPN? Every 24 hours compared to regular tubing, which is what? Every 72 to 96. Both hospitals have 72, and 72 is not wrong. 96 is actually what the CDC says. Okay, but it's just like a party. If you want people to show up on time, you tell them, oh, it's at 3 o'clock, not 4 o'clock, right? That way they trickle in at 3:30. It's like, oh, you're just on time. All right, so yeah, so you got TPN, and you got lipids and blood. Those are the other exceptions, right? And blood will come back when we talk about blood on exam 3, I think, is blood, or final exam. We'll talk about blood and respiratory and such. So yeah, and then lipids, right? So that's kind of the little in between. All right, so then fluids, that's another thing to prevent intraluminal contamination. What if those fluids are up for too long, right? You walk in the room and it says they expired 2 days ago. Is that bad? Yes, or does it expired is a bad word, but if it was dated 2 days ago, is that bad? Yes, right? All right, so that's kind of, how you want to kind of organize all of your stuff. I think I might have mentioned it here once, but like for medications, where did I put meds at? There it is. So every med ever. So in nursing school, you got to know what's the, what class it belongs to, because that's going to help you out. And usually they have suffixes. All right. So if they have suffixes, you know, oh, it belongs to that class, and that class does this thing and has this side effects. And sometimes there are unique meds within the class that have specific side effects or specific things you got to talk about, you think about, right? Like for like what's the one I'm thinking of? The exenatide. What does exenatide belong to? Yeah, so it's the one that causes kidney disease, right? So it's that one's specific. If they have kidney failure, I got to watch out. What other diabetic meds you got to watch out for kidney failure? Metformin, that's a big one, right? And metformin is usually on every exam, you know, when it has to think about diabetes. So you take your little, you know, summative exams at the end, right, with Kaplan and such. It's probably going to give me a metformin question, right? Take your NCLEX, probably going to be a metformin question. It's been around since the 60s. It always has the same thing, where, you know, hold it for what? Two reasons. Why do you hold metformin? That contrast, right? And what else? And then what else besides contrast? CKD, right? So the kidney disease is you go into the kidney disease, acute kidney injury especially, all right? Kind of, there might be a little bit of spectrum in the beginning of kidney disease. You might be okay with it, but definitely once your kidney function starts declining, they got to be off metformin, right? Otherwise, what happens? You get lactic acidosis because it stops the breakdown of lactate, right? So that's why I give you the rationale and the theory behind it, right? It's like, why does he tell me all these mechanisms of actions? That's too much information. Well, if you know that it blocks lactate, then the side effect is lactic acidosis, right? So, and then that means what ABG? Metabolic acidosis, right? Because you've got lactate buildup, right? That's one of your kill you acids, right? And that's going to cause a metabolic acidosis as it sucks up all the bicarb, binds to all the bicarb in the body. Okay. And how do you fix that? How do you fix metabolic acidosis? Well, first, the underlying cause is always the right answer to every disease process ever, is fix the underlying cause. But the underlying cause here is to stop the metformin. All right. That's the problem. They're the drama. All right. What else? How are you going to fix metabolic acidosis? You can give some lactate, yeah, lactate ringers, I mean, right? It's like, well, that's weird. It's not a test question, but I thought, does lactate ringers have lactic acid in it? It does not, right? So what else? How else do you fix metabolic acidosis?
Give insulin.
So if they have, if it's caused by DKA, you fix the DKA. So really, it's fixing underlying cause. This is one where you have to go underlying cause. But yeah, you got to connect the concepts. If it's, kill you, which one of the kill you, you know what I'm talking about with kill you? All right, so K is what? Ketones, right? So how do I fix ketones if ketones are causing metabolic acidosis? That's FIE, right? Fluids, instant electrolytes, right? And then I, ingestions, we didn't really give you any kind of treatment for that. Just don't do it. Don't drink the hand sanitizer on the way out. And then L, right, is what? Lactates, right? And lactate most commonly builds up. Yes, it could be metformin, and we're going to stop the metformin as the treatment. But what's the most common reason for lactate buildup? Infection, right? It's low perfusion technically, right? And in sepsis, you have low perfusion, right? Because someone with like severe heart failure can have poor output enough to cause a rise in lactate. That is a possibility. That's not for this exam. It's just kind of connect the concepts. Lactate builds up when you have decreased O2 delivery, right? Or decreased blood pressure, right? And also in sepsis, it actually interferes with mitochondrial function. So that's going to cause some acidosis as well. All right. That's why I bring it up in lecture and say, hey, this is how this works, right? That way you can connect the concepts on the end. As long as you come out, you can just disregard lecture and just memorize everything. That's perfectly fine. You'll get there too, but not everybody is a savant or has a eidetic memory where they can memorize all these little factoids. All right. So you got to have a little bit of connection with each one of them. Okay. Sometimes the connection make no sense. Like I don't no idea what cell respiration means or glycolysis. I threw that away when I got in the nursing school, right? But what else? You got lactate. Yeah. What if you have metabolic acidosis due to lactate, right? In sepsis, you expect what? For symptoms, we'll say. So symptoms. What do you expect for symptoms?
An SNS response.
Fever, white count, infection stuff, right? And then treatment would be the antibiotics and fluids. And what else? ILU, all right, so uremia and due to kidney failure, and that's kind of more connecting to the final, right? Because that's where you're going to talk about renal failure. Okay, but renal failure leads to what? Yeah, but what symptom? What complication? Because you can't get rid of it. And that was part of the ABG lecture. Potassium is the always the killer. If you have to guess electrolytes and things that will kill you, it's potassium. All right, that's always usually the right answer. All right, so you have high potassium, right? And high potassium. Now we're back to EKGs, and that has what EKG finding? Some peak
Like
T
two.
waves. Hypokalemia causes torsades, not hyperkalemia, right? So I put a little section here. I think when we talk about EKGs, I think I finished this. I get sidetracked. I'm sorry. All right. So yeah. So medications. All right. So before we go back to lights. All right. So medications. You want to know that what's the indication? Why are you giving this medication? Oh, that's a diabetes med. Right. Some have dual function because they were so good at what they did. Right. They were overperformer. Right. They were a brown noser. All right. So they were going up to, I'm trying to think of a more politically correct way to say that. They went and they did such a good job. They caused, which one of your diabetes meds is so good at diabetes, it bled into another disease process.
GLP-1.
GLP-1, that's kind of more like weight loss, but yeah. But what about another disease process you'll be studying on exam 2?
Oh,
it was so good because it got rid of so much fluid and then also got rid of so much weight. That was great. CHF, right? So it's great for CHF, great for diabetes. Which meds were those? The which ones? The SGLT2, is that what I heard? All right, so those guys, those are the ones that do it, right? So yeah, then you want to learn the suffixes for those ones because all of those ones are good for CHF. All of them are good for diabetes, but then we kind of find out some are not so good because they have this terrible side effect, right? But yeah, but for the most part, they are great meds, right? And they have dual functions. You're going to see them, like we on clinical last week, they were on 2 patients, right, in the morning for morning meds. All right, so yeah, so we want to know the suffixes. So hopefully the suffixes make sense and they are, they have the same suffix. Some don't have the same suffix, like our alpha glucosidase inhibitors. Those guys, that's just them, acarbose and miglatol. There's no other good way to memorize them. Okay, a carb makes sense to me because you're without carbs. All right, because you're just going to poop it out. And then if you just poop it out, you get diarrhea, right? And if you get diarrhea, what ABG do you have? If you poop out all the bicarb, right? You get metabolic acidosis. So there's a connection, right? And what else? So yeah, so you want to know the action because that'll help you understand the mechanism of action. That's definitely going to help you understand the side effects, right? So like metformin, we said, blocks lactate production. One of the side effects is lactic acidosis. It is rare, but it's possible. I've seen it probably like 6 times in the past 15 years, but it's like they have severe metabolic acidosis, but they don't have an infection. They're perfectly fine. Maybe in their heart, they don't have heart failure. So let's look at their meds. Maybe one of their meds caused it. Okay. And then side effects. So sometimes there's weird side effects that you can't explain. It's just they get yellow halos. Don't know why. All right. Who has yellow halos? Digoxin, right? So who gets they get a cough when we talk about next time. I'm trying to think of another med you have now, so don't overload you. All right. So yeah, intervention. So what are you going to, like miscellaneous stuff? What are the things you're going to teach them? Like digoxin. You're going to check your apical pulse because why? It lowers the heart rate, right? And interventions for that, you got to look out for dig toxicity, right? And other interventions, just random things that you have to do to make sure they don't get, that we can avoid complications, right? For like BP meds and orthostasis treatment interventions. Trying to think of other things that are related to this exam, sorry. But anyways, that's meds, all right? All right, do we have a motion to approve to go to lights? Yeah, okay. So lights, I think we separated out lights up top. All right, so you got potassium, mag, and calcium. Those are the ones you're concerned with. Sodium has no role in EKGs, ABGs, a little bit of ABG. Well, not really. I mean, you got dehydrated, but definitely with diabetes, you got sodium problems, right? What's the sodium problem in diabetes?
Hypo.
DKA and HHS, right? Are they both high, both low? One high, one low. Which one's low? Which one's high? DKA is low, right? And HHS is high, right? You can just memorize that, but you might get it mixed up. Which one was it? All right. And then, but you can then say, well, you know, in HHS, they're like super, super dehydrated. They can't access water, right? And they're because they're debilitated. And, you know, HHS is what happens if you didn't treat your DKA and you have insulin. So that's kind of how it connects. All right. So that's sodium. That's really the only sodium topics. Any other sodium topics you think of for this exam? All right, so then potassium, mag, and calcium. And again, I wish I could ask you a question on everything you studied, right? I wish that was possible, but I can't. Unfortunately, that's nursing school where you study this much material and there's like this many questions, all right? And those in Zoom land, I put my hands together, all right? So yeah, so that is a, yeah, so there's very little questions sometimes in all the content you studied, right? And then maybe there's like 10 questions on like one specific section you never even touched, all right? So you have to study everything, unfortunately, because there could be questions on anything, right? I try to make it fair. I'll take this and I'll start highlighting things on my own end, and I'll say, oh, I already asked like 3 digoxy questions. Shoot, let's just do 1 digoxy question. Let's find 2 questions elsewhere, all right? So I went to nursing school recently-ish. So I was frustrated when there was like, 10 valve questions. I didn't even study valves, right? So I'll make sure I have, usually a wide spread of knowledge, right? So that's just nursing school in general, right? You've seen TikTok, you've seen people stress, right, about the amount of material. So it's not a one thing Groveman thing. It's a universal thing. So I'm trying to help you as much as I can. All right. So yeah, so potassium, mag, and calcium. So potassium, we talked about high potassium, right? So here's an EKG, which light caused it, right? I didn't really give you EKGs I guess I could, but I didn't really give you like examples, right? We know that high mag and high calcium cause what? High mag and calcium. Bradycardias, right? So yeah, you could have a bradycardia and which one of these lights caused it, right? Or you have the peak T waves and the wide stuff, which one caused it, right? And then low potassium, right? So I didn't really give you the EKG changes for low potassium, but you know that low potassium causes what? Causes ectopy, right? So you have PACs, PVCs, probably, you're going to check potassium. What else would you check? Check a K levels. Like, oh, K is 1.9. That might explain why they have ectopy. And what other lab results would be 0.7 that might cause ectopy? Magnesium, right? So low mag, low K cause ectopy. What else does low mag cause? Torsades, right? So that's really the connection there. So you got a rhythm, and you got to interpret it. It's not going to say this rhythm is on the monitor. It is torsades, right? It's going to say this is the rhythm in front of you on the monitor, right? Because even the monitors now, the GE monitors and the Philips monitors at both hospitals, they don't say torsades. All they say is they might say VTAC, they might say AFib, right? But they don't say, SVT. That requires, some human thought, right? That's why you're getting trained and get licenses to interpret this stuff. Okay, so you interpret, oh shoot, that is torsades, right? So you have to recognize, and that's step 1. That's your kind of your general category. Step 1, interpret it, and then step 2, what are the causes? So you're looking at what? Low mag, right? And low K we said could cause it too. I think we said low calcium also, so they can lead to that. All right, but really mag is like the number 1 because that's the key, or the motor oil we decided, right? To all the protein channels to reabsorb all the other lights. Okay. Yes. Yeah, so ectopy is PACs and PVCs, right? And PJCs if you're fancy, but not an exam. All right, so yeah, so we have low mag, low K, low calcium. Who has low phos? Did I mention that? I don't know if I did. Low phos is your DKA patients. They're using all kinds of energies. That's some of the lights you check for those guys. Either way, we didn't connect any kind of EKG changes to that, and there aren't any really. So what else on lights? Yeah, DKA patients spend a lot of energies. They waste a lot of ATP, right? All right, what other stuff on lights? Are you good on lights? Good.
Honestly, looking at the study guide actually really helps me today.
Yeah, so, I mean, it is the same material, but it's just kind of, I just took out the other stuff, right? The reasoning behind it. So now you're just like, no, I know why it's Brady, or I know it's why they have this, or I know why I check the PR interval for this medication. That's the idea. So it's not just straight up memorization. It's like, okay, beta blockers, PR interval, beta blockers, PR interval. And then it gets all mixed in your head with alphabet soup. So was it beta blockers QT or beta blockers, RR? Which one was it? Right. So you want to be able to try to connect the concepts and the why. So you put the rationale, when I'm making tables, I usually put the rationale behind every symptom, but I can. Then I realize I have like 6 symptoms and they all says because of SNS, because of SNS, because of SNS, because of SNS. So then I'll just group that together. SNS response is the symptom, right? And these are all the symptoms behind it. And then it has something weird, like they have, some circumoral paresthesias. Okay, cool. All right, so that's the other thing. All right, or carpopedal spasms or whatever else. Okay, all right, where do you want to go next? Mm-hmm.
On the P rate and the R rate.
So many care plans, P rate and R rate. So when would you have a different P rate than an R rate? 3rd degree block, that's why. So it's like, what is your P to P, P to P, P to P? And if that's different than your R to R, R to R, that means you're divorced, right? So that's the why it's there. And also P rate can mean like a flutter, like if it's like super, super fast, like P to P is like right there, really, really small. That can tell you that you have like 6 P waves in a row. That could be, that's a flutter. So that's another reason. Yes, we had someone raise their hand. I'm hallucinating. All right, if I'm hallucinating, I would get what medication? Get what medication if I'm hallucinating? Antipsychotic, right? And antipsychotics cause what EKG change? Prolonged QTs, right? Which is what's prolonged. Greater than 0.45, right? But there's not going to be a question that says, QTs greater than 0.45 is prolonged, right? That's a knowledge-based question. So how would you know it's greater than 0.45? You have to measure it, right? How many boxes is that? So 2 big ones at least, because that 2 big ones is 0.40, right? And at least 2 small boxes, right? That would tell you have a prolonged QT. Then you're thinking, well, what is prolonged QT? So puts me at risk for torsades, but what else? Prolonged QT. Amiodarone could have caused it. Prolonged QTC. We've got meds here. So there's our haloperidol, right? So example of an antipsychotic. What was my question? I lost my train of thought. Okay, so what prolongs it, like amio, right, would prolong it. You're at risk for torsades, but torsades does not cause prolonged QT. Prolonged QT causes torsades. And we got our meds there, right? We got our antibiotics, antiarrhythmics, such as amio. Okay. So we're not gonna be really, and then, so all your meds can cause, your cardiac meds especially, can cause some interval changes, right? So we talked about QT, what's the other important interval? PR interval, right? So that's your, which one of these meds cause a prolonged PR, right? Yeah, B, C, and D do. Okay. All right, that's a lot of EKG stuff. Do you want to do something else or do you want to keep going? Where do you want to go? So diabetes, what do you want to know about diabetes? Has a lot of complications, right? ABGs, and we can connect diabetes to ABGs, right? So knowing type 1 versus type 2, right? Which one has, a thin appearance? Which one has a bigger appearance? Which one has A1C elevation? Both of them. And what is the A1C that's bad? Greater than 6, well, you say 13 is bad, but greater than 6.5 is considered what? Diabetes, right? You get it, it's like confetti goes up, diabetes, right? So that is a sign of, that's a sign of what? Poor glucose control for how long? About 3 months or so. Okay. So yeah, so if you're a diabetic patient, they come in and say, hey, my A1C is 8. It's like, well, that's not good. We gotta get that down. Okay. So what else about diabetes? So type 1 versus type 2, as far as like who gets TKA, who doesn't, what are your complications? Because they both present with complications, right? Both of them can present with like a poor healing wound or a trouble seeing or trouble EDing. Okay, so that is those are complications, right? Your type 1 usually presents with DKA. That's like in the first symptom they present with, right? It's a misorganization, I guess you would say, when they say, oh, these are type 1 diabetes symptoms, Kussmaul breathing. No, that's a complication of type 1. The symptoms of both type 1 and type 2 are the same. And what are those symptoms? Yeah, the 3 Ps, right? And dehydration and SNS, right? Dehydration means low blood pressure, and that's an SNS response, right? Minus probably the diaphoresis if it's severe dehydration, right? So hot and dry, what does that mean? Sugar's high, right? So they're dehydrated, and you get febrile because you're losing water to the skin. Your ability to get rid of heat is by vasodilating and getting rid of water and diaphoresing. So that's why you're hot. All right, that's why pregnant ladies are always hot. All right, they're dehydrated. All right, what else about diabetes? All right, so you got to know the generic stuff, like what are your causes, risk, / risk factors. What are your symptoms? You got symptoms there, right? And usually that's going to bleed into complications, but you want to be able to distinguish that. Like, oh, that's a complication. But yes, they could present with a necrotic foot. They could present with a trouble seeing, or with a heart attack or a stroke. They could present like that, and they just didn't know they had it all along. All right, and then treatments. There's meds, all right, for treatments. All right, everyone's getting on the med train in the pharmaceutical world. So there's like 10 different medication categories. All right, and why do I have to know all these meds? Because they're going to prescribe them, right? So we have to know the meds. You don't have to know which med is the best. You don't have to know which med is I should prescribe next, because you are not prescribing meds, right? That's an NP or a MD that's doing that, prescribing meds. You just have to know they could prescribe this, and then if they prescribe this, I got to tell them that was wrong because they have renal failure, right? Or that was wrong because they have CHF, right? So that's your job, is to know the side effects of those meds and some little tidbits about holding it for contrast or not. Okay, so that's why you have to know all these things, right? I can't just say, oh, just know half of them, because maybe they won't prescribe the other half, right? That's irresponsible on my part, right? So yeah, so there's meds, PO meds, and there's what other meds? Insulins, right? What do you have to know about insulin? What's fast, what's long, what's short, right? How do you give it? Which have no peak. Okay, so those are your insulins. And then surgery we're not going to focus on. But that is an option. They can get surgery as long as they are with the program and have a good mindset and are doing their things. Exercise. What about exercise? Hopefully don't get to this point. There's always a little triangle, right? Of of drugs, but we try meds, sorry, not drugs, diet, meds, and exercise, right? DME. So diet, what do we recommend for diet? I didn't fill it out, but yeah, so you have good carbs, all right, good fats, and good proteins. Okay, so what kind of diets do they like? Mm-hmm. So you got keto, plant-based. Plant-based is preferred. Plant-based, Mediterranean hasn't been disproven yet since like early 2000s. And keto, right? It's like, well, that may put in ketoacidosis. They got to be careful, right? So they got to be measuring the ketones and all the other fun stuff. And it's yeah. All right, so good carbs, good fats, good proteins. You should know that's just kind of, what does that mean? All right, I kind of give you a lot of examples on the slides. And exercise, what are some exercise tips and tricks? Y'all with the sim, right? All right, so they got to bring snacks like whole grain oatmeal, right? I'm kidding. That someone said that in sim. That's fine. Check your glucose, right? So that way they aren't just going to get what? Hypoglycemic, or they might have discovered one morning they're already in DKA, right? Because their ketones are what? Present or high, right? Because it's not time to exercise when you have ketogenesis going. Know when your meds peak, right? Don't put the insulin where you're going to muscle. Bring a friend, all right? For metabolic bracelet and all that fun stuff, right? And they have to be exercising for how long? 150 minutes or 10K steps per day. All right, so that's diet, exercise, pharmaceutical stuff, right? What's so hot? SGLT2s, right? They're for CHF also. All right. And then acute complications, hypoglycemia and hyperglycemia. So you should recognize, oh, they're worse for hypoglycemia. Let me go and check a blood sugar. All right. They might have symptoms that prompt you to do that. All right. What are symptoms of hypoglycemia? So they're going to be not getting the sugar to their brains. They can get altered, but what's unique? And also when you have low sugar, what else happens? The first thing that happens is tachy. Why? It's an SNS response, right? So now, so like if you were to like even discover before, it's like, oh, those are all SNS responses, right? That can reduce your table size, reduce your concept map size, right? So they have what SNS responses? Tachycardia, what else? Palpitations is because of tachycardia, yeah. And they got tachypnea, right? Which is what? Fast breathing, right? They get diaphoresis. These guys are on dehydrated, right? Like in hyperglycemia, which also has SNS symptoms. All right, they have very, very profound diaphoresis, right? Yeah, and their pupils might be dilated, and they might have a feeling of impending doom and anxiety too. So they're cold because their BP is rerouting blood, or the blood is rerouting blood away from their skin to the core, right? Those are all SNS changes, and you can copy and paste those for 99% of disease processes, right? So that's why we're learning it now. All right, so then we're going with that. So then what caused it? So we know what's, oh shoot, they're hypoglycemic, all right? So you have to recognize that because that is as dangerous. In a diabetic, you need to recognize they're hypoglycemic or hyperglycemic. That means it's not managing or there's something else that can cause them to be hyperglycemic. So we got to recognize those two things, all right? So guarantee there's two questions. One, are they hypoglycemic? And what do I do about it? Or what are the causes, right? And two, they're hyperglycemic. What are the causes? How do I fix it? So which one do you want to do first? Hypoglycemic. So if they're hypoglycemic, the sugar's low. Why is their sugar low? They didn't eat. And what else happened? They took their insulin and didn't eat, right? So that's like at home. So I kind of grouped it into home and hospital, right? Yes, there can be overlap, right? They can exercise in the hospital and inject in their thighs, sure, right? But like I guess an ARU maybe, right? It's like, oh, you get your insulin, it's put in your thigh, and then they go ahead and they go on the treadmill that day. And they're hypoglycemic, all right? But more commonly in the hospital, they're not eating, right? Why aren't they eating? They're MPO, right? I stress eat. I don't know about you, but yeah, so they are MPO, right? Or they're just super sick and they're vomiting all the time, right? So that can happen too. They're like, we gave their insulin and they just now 5 minutes later, now they're vomiting, right? It's a poltergeist scene, all right? So it's like, well, I guess they're not eating breakfast today, right? So then that puts you at risk for what? Yeah, it could put you at risk for metabolic alkalosis, but it's gonna put at risk for acutely hypoglycemia, right? Because they're not eating and you gave insulin, right? So I only got 10 to 20 minutes. Well, shoot, what do I do, right? So discontinuing the steroids is not the best option at that time, and that's not something we could do independently. Good reason, but let's do the vomit train. What are we gonna do with that? Give an antiemetic, and what else can we do? Make sure they have some dextrose. And how do you make sure they have some dextrose? You can hang some D5, right? And they start getting symptomatic, like they tray was given, they start vomiting, and it's like, oh, now they're at risk for hypoglycemia. I gave the insulin, so now I should try to feed them some long-acting carbs, or get them some, and that's not working. They keep vomiting. It's like, okay, I bet I should stop that. And let's hang some dextrose, right? You can call the provider for some dextrose solution, right? D5 water is usually going to be good enough. If they have persistent hypoglycemia, we might even start a D10 water drip infusion. But in the meantime, let's say you forgot to start D5 water, and then you come back an hour later and they are hypoglycemic. What are the symptoms of hypoglycemia? The monitor tech calls you and says, hey, your patient went to AFib RVR. It's like, you're like, oh, that's a tachyarrhythmia. Why are they tachyarrhythmic right now? What caused it? Are they hypoxic? Nope, stats are 96%, right? Are they acidotic? Nope, they're here for a hip fracture, right? Or hip fractures but are they bleeding out? Nope, their blood pressure's not low, right? So then what's the other trigger for the SNS? Low blood sugar, right? So that's why we would teach you the lows and the highs that could cause a response. Like, is it high CO2? Or they stop breathing? Or they go in the room? Nope, they're breathing, right? So, and they're breathing fast because they have an SNS response, right? So they have what? They have a hypoglycemia because they got their insulin in the morning and they are not eating, right? So what do? You can check the blood sugar, right? You can check the blood sugar and it's 42. What do you do? See if they can eat. And if they can't eat, they've been vomiting all morning. So we know that's off the table, right? So what's next? See if they have an IV, all right? So make an algorithm if you can, because you can memorize all the different options here, but it gets redundant, it gets ridiculous after a while. Are they awake with PO, awake with NPO? Are they not awake with PO and not awake with NPO? Are they awake with an IV or not awake with an IV? That's too much stuff. So if you get an algorithm going and you could say, okay, first off, hypoglycemia, I got to check, are they awake or not? You can do that first, or you could do IV or not. Either way, I think on the PowerPoint I gave you, are they awake or not? Because if they're awake, you can usually give it some PO, right? But this guy, not awake, he's not, let's just say he's awake right now, okay? So if he's awake, not able to take PO, then I have the other option. What's the other option? So yeah, you can get IM. So the next option is first, the next flow chart, next branch is IV, yes or no, right? If he has an IV, what can I do? I give D50, right? And usually most protocols are half an amp. And then the other option is what? They have no IV. Is give IM what? Glucagon, right? And what else is glucagon used for? Beta blocker and calcium blockers, right? And if I give it for any one of these three cases, what do I have to worry about? Poltergeist, right? So I have to worry about I have to turn them to the side and say, okay, we're going to turn you to your side. Oh, your bed's really wet, isn't it? All right. So because they're diaphoretic from hypoglycemia. All right. So then you can take that to a next step. Let's say you did not come back in 15 minutes like you're supposed to, right? And now the sugar is what? Even lower, it's 26. All right. So then you have to say, well, now they're not awake, right? So what do I got to do now? And he pulled his IV out. I am glucagon again, right? But his IV was still in there, then you would go ahead and give the IV push of dextrose, right? Usually a full amp at this point. So you keep this process going every 15 minutes until he's the sugar's over 70 times 2 usually. Okay, and then you're gonna get an order for that D5 water you forgot to ask for, right? And if it's like persistently low, maybe D10. So does that make sense, right? I was going to go somewhere else with that, but oh yes, the symptoms. So we got hypoglycemia symptoms. You got the SNS firing. What else are there symptoms of? Of neuroglycopenia, which is what? Focal neurodeficits. They look like stroke-like symptoms. They have slurred speech all of a sudden, right? You went in at 7 o'clock and they were perfectly fine. Now they have slurred speech. Okay, so it could be the hypoglycemia. And then they start getting altered and comatose or altered seizures, comatose. All right, so that's hypoglycemia. What about hyperglycemia? And someone else mentioned other causes. It might get hypoglycemic. Is their steroids where the steroids are just cortisol, right? And cortisol does what usually? Raises it, right? That's why it's called a glucocorticoid. An oid is steroids. Glucocorticoids are your steroids, are your steroids that raise blood sugar, raise your glucose, right? So they went up or down on steroids that caused hypoglycemia. They went down on steroids, right? And they were still getting their long-acting insulin, such as what? Lantus, there's no brand names on the test. Glargine, right? Not glulisine, but glargine, right? All right, so yeah, so they got their long-acting insulin the night before, and now they are hypoglycemic because someone discontinued the steroids or reduced the steroids. And yeah, so there's other causes there, right? So then what about hyperglycemia? All right, so yeah, you can think of just what's causing DKA, right? Maybe they're getting infections. They're brewing an infection because they weren't moving in bed. Someone did not raise the head of bed, and someone did not offer IS. Right? So yeah, so that could be, that's a sacrilege, right? Did they even go to nursing school? Did you graduate from Florida? Anyways, oh my God. What else? So what else could cause hyperglycemia? Yeah, so you got some stress, right? Iatrogenic, that was our fault, right? What we do, we got a D10 infusion, or that patient the day before, oh, they had hypoglycemia yesterday. Next day you go, oh, they had hypoglycemia 2 days ago. Not gonna let that happen, still got the D10 water going, right? And now there's I'm really, really thirsty, right? And then you like, I was like, yeah, I've emptied your urine like 6 times today. What's going on, right? And it's like, and then the monitor calls you, hey, they're an AFib again, right? So what does that mean? You got an SNS response happening, right? They're tachycardic, tachypnic, They got the 3 Ps, right? They are hyperglycemic. Okay. And then how do you fix that? Yeah, you prevent, you're going to make sure they're not going into HHS or DKA, right? But, you know, hopefully they have access to water, but maybe they're vomiting. But when you're vomiting, you can still be able to take some water, hopefully. But anyways, you got to see, well, we got to fix the underlying cause. You're getting an infection, right? So we got to look for lactate and other things. All right. So it's just like all the fixes for hyperglycemia. All right. Make sure they're not getting into DK, and especially for your type 1s. All right, does that make sense for hyperglycemia? All right, and then that hyperglycemia dovetails into DK and HHS, right? So what's the difference? One makes ketones, right? And when do you make ketones? When you don't have insulin, right? Who doesn't have insulin? Who has a deficiency, an absolute deficiency of insulin? Type 1s, right? Because you still have insulin in type 2s, you don't go make ketones. That's for why HS does not have, cannot occur in type 1s. Okay, so what else? So DK causes, we mentioned some I's, right? I kind of narrowed it down to 3 I's. Yes, there's 8 I's, but I kind of try to group them together as best as possible, but you can do the 8. All right, so infection, we got our, you know, insulin deficient or, you know, iatrogenic, we didn't give the insulin, maybe, all right? Incredible stress, they got cortisol release because they have a disease process that's causing it. And when you're in the ICU, you can use up all of your glycogen stores. You can even be hypoglycemic, but most commonly, the first step is we're going to go into DK. Okay, and then what are your symptoms? We mentioned the symptoms a couple times, but it has DK and A, right? So they're acidotic. So it's like, which one of these would you expect for your DK patient, right? Or which one of these ABGs would you expect for your HHS patient? What ABG would you expect for HHS patient? Not acidotic. So the pH is 7.34, or really we gave 7.30, but I wish they were 7.35, but they're not, because that's just what these international societies decided on one Tuesday on the top of a mountain in Dr. Evil's lair. They decided, hey, we're going to make it 7.30. We're not going to make it easy for nursing students to know this. Okay. But yes, because you can be a little bit acidotic, just it might be something causing the HHS, like an infection, right? Might have been causing it. So yeah, so it's not exactly, unfortunately, these are not acidotic, like not severe acidosis, I guess you would say. But anion gap is definitely going to be, you know, 12-ish, because they're not going to be making keto acids. Okay. And then going back to DKA symptoms, right? So, or back to that example, you have an ABG, right? Which one of these ABGs is DK? Which one of these ABGs is HHS, right? So give me an ABG for DK. They have metabolic acidosis, right? But it's not going to say metabolic acidosis. It's going to have an ABG. So give me an ABG. So 7.21, as long as it's less than 7.30, right? It's going to be, again, I said it was going to be obvious, right? It's not going to be, it's 7.29 or it's 7.31. So what you said HHS was this? It's going to be obvious that they have acidosis, right? It's not going to be a 21 bicarb. It's going to be a what? A 12 bicarb maybe, right? Or even a 3 or 5. Right? Because the bicarb was the drama, right? That's the one that was causing the low pH, right? You expect the CO2 to be what? I'll make it obvious. It'll be probably low. Why? Why is it be low? Because they're breathing fast, right? When you breathe fast, you blow off CO2, right? So that's the ABG example. You have to select the correct ABG for DK. It's like ABG for HHS, right? What else? So the treatment we mentioned, right? So our diagnostic tests are going to be, you know, GAPs, blood glucoses, and ABGs. ABGs, obviously, we're going to make sure we got the right ABGs. Like, oh, your ABG shows, you know, you got to call that into the provider, let them know they have, that's a really bad ABG. The bicarb is really low or the pH is really low, right? And other do labs every 4 hours with chemistries, basic metabolic panels, because we want to look for what? Potassium changes, right? So potassium, they've been peeing it out for maybe a day or 2 or 3 days, and so it's low, and they're getting acidotic, so decay is going to the cells, but we need to replace that. So that's something to be alert to. But acutely, they can be hyperkalemic. I've said it backwards. They get acidotic, and the decay comes out of the cells. Like, oh, they're hyperkalemic. right? So, but they're not truly hyperkalemic because they were just diuresing all that K the whole time. But once that K falls below 5, we got to correct that, right? And what else? So then like the sugar story, all right? So we don't care about the sugar in DKHS. We care about what? The anion gap, and especially in DK, because you're not going to have an elevated anion gap in HS. Because when the anion gap gets closed, that means their DK is resolved and they're not making any more keto acids. Because anion gap is a measure of what? Of how acidotic they are, right? Right. So treatment fluids, insulin electrolytes, fluids because they were 3-peeing, all the, like 3x peeing. All right. So they were peeing a lot, and then therefore we got to replace the fluids. All right. So 50 mLs per kilo per 4 hours. They weigh 80 kilos. How much is that?
I'm sorry, you don't get that one.
We had to replace fluids, and it should be 50 mLs per kilo in 4 hours. How much is that? I heard a lot. Yes, it is a lot. How much? 4 liters, right? So you have to give them, make sure we don't give any more than 4 liters in 4 hours. Doctor said, oh, give them 8 more liters. It's like, no, not gonna do it. That's way too much, right? Or they say, oh no, just only give them 1 liter. I don't think that's, that we should be good after 1 liter. It's like, well, it should be 4 liters. Okay. And there are situations where it would be, we have to be conservative, like with renal failure and CHF, but that's later. Okay. And insulin, what insulin? Regular insulin and lights, right? We've talked about the potassium. We got to be very, very diligent on potassium. Otherwise, your patient starts having ectopy on the monitor, and they have DK, and they're getting treated for DK. So what electrolyte issue are they at risk for? Hypokalemia for resolution of DK because someone didn't replace the potassium. All right, where else do you want to go next? I'm improving. I just want to make sure I want this one to be useful for you too.
I think we really haven't covered central line.
No, we talked about lines at the beginning. What other topic? Anybody in Zoom land? We got an indecisive group. Yes, in the back. So anion gap, again, what is anion gap for? It's for how acidotic are you? There are 2 exceptions. 8 to 9 times out of 10. Well, let's say 8. 8 times out of 10, it's going to be because you're measuring how acidotic they are, right? There's 26 AGs. Let's hold on. Anion gap. All right. So there are. It's measuring how acidotic you are, and 8 times out of 10, those are acids, like the kill you acids, right? Such as ketones, right? Alcohol is cool. And then lactate, and then potassium and hydrogen for renal failure. So that can tell you that those are getting worse, right? When your anion gap is greater than what? Greater than 12. That's 8 times out of 10. The other 2 little times are when you get sodium chloride, or when you are doing, what's another cause of metabolic acidosis? Diarrhea, right? So diarrhea and sodium chloride, those are the exceptions. But 8 times out of 10, it's going to be an acidosis situation, right? You're making more ketones, anion gap's elevated. You're making more lactate, anion gap's elevated. You're hyperkalemic, your anion gap is elevated, right? Any questions? So that's what it is. That's all anion gap is. It's a lab value, and it tells you information that they are getting more acidotic, right? And people always avoid looking at it because it's on every single basic metabolic panel ever, and everybody gets those, right? And usually people get 2 or 3 in a row, or 2 or 3 days in a row at least. So you can see, oh, anion gap's 12, 16, 24. Something's wrong, right? So you got to look, well, what's the kidney function looked at? That's your U, right? What's the ketones? Are they diabetic, right? That's kind of where we look at. Yes.
Goal close the anion gap. So the goal is to close the anion gap and then fix the blood glucose level.
No, that's you're already doing FIE to fix the underlying process, right? To stop ketosis and to replace and fix dehydration, right? So the question was, I don't think they can hear you. The question was, what's the goal of decay. So the goal of decay is, of course, to treat the underlying cause, right? That's always the right answer. But where the underlying cause was ketosis, right? And how do we know we fix ketosis? Ketoacidosis is the acidosis resolved, right? So we closed the anion gap. So blood glucose don't care about. 100% don't care about blood glucose, right? The insulin is not to bring down the glucose. The insulin is to fix the ketosis, right? You need insulin to stop ketosis. Yeah, so if they are truly hyperkalemic, then we have medications for that, and we can go there next. Just remind me because I forget. But yeah, so you want to close the anion gap, right? And when you do the measurements, you can see it's closing. You can say, oh, we're making that number narrower, right? Or bringing it down from 40 all the way down to 12. All right, so yeah, so hyperkalemia. Who gets hyperkalemic? Yeah, CKD, but diabetes can cause CKD as a complication. So other hyperkalemia situations would be so we get potassium not paying attention. They're on case-bearing diuretics. They're on acetazolamide for too long. What else? All these are leading to what umbrella term? Yeah, but I'm asking what the cause of hyperkalemia is. There's fluid electrolytes from last semester, right? What kind? What flavor? What flavor of acidosis? Metabolic acidosis, right? That's what I'm getting at. So metabolic acidosis is will result from hyperkalemia. Hyperkalemia is a cause of metabolic acidosis, right? So how do we fix hyperkalemia? What are the treatments for it? Not sure if I have it on here or not. That's what I need to search for, a cocktail. Nope, no more cocks. All right, so yeah, so we got to look for cocktails. So what's your potassium cocktail? Where's a good place to put it? Maybe at the top with high K. Oh, there it is. Okay, let's put cock there just so we got that. All right, so we got how do we fix it? Our priority is what? The heart, right? Your heart's always all your priority, right? That doesn't work, then you have to. Then we don't care about anything else, right? When you lose your pulse, right? What do? Do we do airway first? No, we do C first. We do the heart first. We do CPR, right? Your airway can wait. You have about 1,000 mLs of vital capacity, and if your VO2, if your use of oxygen is the same, then you got about 3 to 5 minutes. All right. So anyway, it depends how sick you are. Either way, hyperpotassium cocktail. So we got to think about the heart first, and then you've got an EKG, right? And oh shoot, that EKG looks like hyperkalemia. Let me check the potassium level. The potassium level is 7. Okay. So hyperkalemia, they have a K of 7, and therefore we got to fix the heart first, right? And when you give this calcium, it's like Hollywood. You give the push of calcium, and whoosh, it fixes all of a sudden, right? It's one of those meds that are actually like Hollywood. Okay, giving D50 is like Hollywood too, as long as they didn't cause permanent neurological damage. All right, so hyperkalemia, you give calcium is a priority as long as if they have EKG changes, we give calcium. End of story, right? And then we give the other stuff, right? So which calciums? Calcium chloride, right? And calcium gluconate, which is the extravasant, or vesicant, I should say. Calcium chloride is a vesicant, right? Because a vesicant, when it infiltrates, is an extravasant, right? So yeah, so EKG changes, then we got to get calcium on board, right? And then now we can hide the potassium, right? We can push it aside underneath all the rugs, right? Until we can get rid of it, right? Until we can pee it out or poop it out, right? So peeing it out, yes, diuretics, but diuretics take time to onset, and they have to pee, and sometimes it might be in kidney failure, which is one of our causes of hyperkalemia, right? But we can definitely hide it in the meantime. That therefore doesn't make them more acidotic, right? Push the potassium in the cell. That way we can reduce or fix the pH. What's that?
So that you could stabilize them and then you can get them on dialysis.
Yes, you can stabilize them, and then if they need dialysis, we can dialyze them. And we'll talk about dialysis in CKD, towards exam 3, I think. Okay. So yes, so we have albuterol, not what albuterol is a what? It's a bronchodilator, but what's the class of medication? It's a beta agonist, right? So it has OL, not LOL, right? So expect to not choose the LOL, right? And choose the OL, right? Or vice versa. All right, so albuterol is your go-to med. And then it's usually over 4 hours. It's kind of like, it's going to be like you get to multitask, right? So you're going to get some albuterol going, or you get some insulin going and D50 going. What kind of insulin? Regular IV insulin. It's usually emergent situation. It's a cocktail, right? It's a fluid cocktail, right? And then that'd be a great bar. It's like they turn the albuterol on, and then you could get your little calcium drink. That'd be gross if it was milk, but anyways, you're going to get some glucose and some D50, right? And the glucose is really the one that's exchanging or is pushing the potassium in the cell, right? And how do you get glucose into any cell? You have to mobilize the GLUT4 receptors, right? And you have to exercise. Like, okay, sir, exercise. No, they're not in exercise condition right now. So we have to give them some insulin, right? And before you give insulin, like the sugar could be 42, right? So we got to check the sugar first. All right, and then we can pee or poop it out. So we can pee and give some diuretics, not some case-sparing diuretics like spironolactone and such, but we're going to give potassium wasted diuretics. And our go-to, right? You'll see every cardiologist, waistband, they have a little holster and there's Lasix inside. All right. And then you can poo it out. You got 3 options to poo it out. What are your 3 options? Sodium zirconium, all right? It's like that's the ring you give to your girlfriend, right? A promise ring. I got you a zirconium ring. And you can give what else? Patiramir, right? Patiramir is for it's usually for dialysis patients, but it can still work. And then we can give SPS if it was 2013. Okay. But it's still prescribed, therefore we still got to tell it to you, right? All right. So what else? Where do we go next? Or are you good? All right, so we talked about ABGs, we talked about diabetes, we talked about EKGs, and we talked about lines. Those are your 4 topics, right? For DK, would that be considered a banana bag? So banana bags have been retired like 2010. We don't do banana bags anymore. Banana bags are for ETOH.
We do questions and answers.
Yeah.
Yes.
All this work with chronic catheter, the TPA dwells, so give this to a patient on heparin. So what do you
So
need?
for lines and TPA, right? So TPA we associate with stroke, but stroke is coming up for exam 3. So but TPA has a lot of uses, and it can be used for like a PE, right? But it can also be used to break down, to do what? Break down what? Break down clots. It's a clot buster, right? It activates your natural clot busting enzymes, plasmin, right? It's a tissue plasmin activator. All right, so it's going to break down the clots, the dingleberries that are inside the catheter, right? You don't give it to the patient because they don't have a stroke, right? And they don't have any issue. They don't have a pulmonary embolism you have to break apart. We just want it to be inside the catheter itself. All right, you let it dwell there, and then once it breaks apart, then we can aspirate and then flush with what kind of method? Lamaze, right? So then you're going to go ahead and push, pause, he, who, right? Not Michael Jackson. He. What's that? Yeah, you don't just flush it in. Yeah, you don't flush it in. It just dwells. Okay. What else dwells inside of a lumen? So heparin or citrate can dwell. Okay. Citrate is preferred. Heparin is so 2015. Unless you want to cause problems with heparin. All right. What do you want to do next? So ABG and compensation, right? So we talked about, so we give some example ABG here. Let's pull up another document. Let's go over here. All right, so week spring 2023. Let's make it in the exam one folder. Then with study tools. Yep. All right, so give me some ABGs, give me some numbers. 5, 2. Give me another. What's next? PCO2, right? Give me PCO2.
20.
28. That's all you need, but give me a bicarb. Or I'll give you a bicarb. Let's do no, we can do let's do 20. Okay, what is that? That's first step is alkalosis, right? And then what's next? What caused it? Respiratory cause, because the CO2 was low, right? And then what is the bicarb? It's abnormal, therefore it's what? Partially compensated, right? Partially compensated respiratory alkalosis. What if it was this? Then what is it? It's uncompensated, right? Respiratory alkalosis. What if it was this? So fully compensated, right? Respiratory alkalosis. All right, so you see you can do an algorithm for this too, right? So like what is, where am I at? So first step is always get the, is acidosis or alkalosis. You can do the tic-tac-toe method or whatever helps. Did tic-tac-toe method help you with fully compensated or not? No, that's why I choose this method, because whatever you can do initially, that's fine, but you got to be able to get to the right answer. Okay, all right, more? Give me another number, give me another pH.
1.28.
All right, give me a CO2. 40. All right, let's do a bicarb of this. What is that? So the first step is the pH. What's the pH? Acidosis, right? And then what caused it? Which one of those two is acidosis? The 13, right? The bicarb is acidosis. Therefore, bicarb is always metabolic. And then now what is this? Fully compensated, partially compensated, or uncompensated? Why is it uncompensated? Because the CO2 didn't move, right? So what if we did this? Let's be more efficient here. Okay, what if it was a how would I make this partially compensated? 48, that'd be mixed acidosis. They're crashing, they're gonna die. Okay. Then how do I make this fully compensated? As long as less than 4.0, then I can say that is still acidosis. If I said 4.40, I don't know what caused it then, right? I mean, I could guess, but 4.41, now we're talking about alkalosis, right? That'd be 7.41 is alkalosis. So you got to hit these from every angle, right? So you see how we reverse engineered that? We had the answer first and then try to make an ABG out of it. Yes, question. The treatments, sure. Let's go to the top. How do you treat that? Well, they're both. We got respiratory alkalosis and we have respiratory. How do you fix a respiratory alkalosis? So what are you doing in respiratory alkalosis? Are you breathing fast or slow? So they're breathing fast, right? So yeah, paper or plastic, right? What's paper? Just a paper bag. When have you last seen a paper bag on the floor? Besides during COVID, when they told us to put your N95 in there and use it for 2 months. Huh? Yeah, non-rebreather plastic without oxygen, right? All we gotta do is rebreathe the CO2, right? Breathing fast, right? Paper or plastic, and then we can also do what? Thinking of anti-anxiety medication, right? Or an antipsychotic. Maybe they are really getting crazy, right? They're breathing fast because they are out of control, right? They think it's a zombie apocalypse, like The Last of Us. Right, and then now we're concerned with antipsychotics about QTC, right? So before you give it, you should be looking at what the QTC is, right? Don't give it afterwards, like, look at that, that's torsades. Aren't I smart? Okay, so that's what we're teaching you is I assess the EKG first, right? And yes, you could spell that all out in the interventions column, assess the QTC before you give the antipsychotic. But that's, you know, we got time to, we don't have time to waste. All right. And we want to be as efficient as possible. But if that doesn't make sense, go ahead and spell it out that way. And the first time you write it, you won't need it the second time. All right. Anti-anxiety. How do we fix anxiety? Benzos. What are benzos?
Tranquilizers.
All right. And then they might be in pain because they're breathing fast, right? So talk about guided imagery, yoga, right? Savasana. If that doesn't work, crystals, right? Horoscopes. What else? What else can we do? Opiates, all right? Hopefully, usually start antipyretics like Tylenol and NSAIDs first, but you know, opiates can possible pain meds, right? NSAIDs, opiates, but which one are we concerned about for this exam? Opiates, right? Because they could need what? Might be reversal of naloxone, right? Narcan is not on the test. Naloxone might be, right? And but for PAMs and LAMs, how do we reverse those? And I've forgotten which one's the brand name. I believe Romazicon is the brand name.
I thought that was on the slide.
Romazicon is the actual name. So okay, Romazicon is benzos, right? And flumazenil is benzos also. So it still has the Z, which is nice. They thought about us. All right. All right. Anything else for respiratory alkalosis you can fix? The breathing fast and nursing considerations. So they're breathing really fast. That requires energy. It requires age, because if you get older and you're breathing fast, you can crump a lot faster than someone that's younger, right? It could be asthmatics. Right? I think younger, I associate that with asthmatics and breathing, right? It's asthmatic. What do we do? Give albuterol, right? Bronchodilate. All right, so you can bronchodilate them, right? And then, like we're saying, you know, if they're getting tired, then we need to be worried about what?
Rebound acidosis.
Yep, so respiratory acidosis, right? Not metabolic acidosis, but respiratory. But yeah, they can be breathing fast because they have an infection too, right? But really, we give you a metabolic acidosis question in that case. It'll be compensating. But just saying breathing fast is not always respiratory alkalosis. You could be breathing fast because you have an acidosis. And if it's a respiratory cause, it's respiratory, right? And if it's a metabolic acidosis, that's where we're going to put the infection at. But there is overlap. The first step is acidosis. Oh, the pH is low. Let's look what else could be causing it. And we usually, you don't just get a pH, you get the whole package, right? All right, you want to treat metabolic acidosis? All right, so how do you fix it? So like we said, they're usually breathing fast, like this person was breathing fast and corrected their pH. Congratulations, right? They made it. They get to ring the bell on the way out. So how do you fix that? We got to figure out the causes of metabolic acidosis and treat the underlying cause, right? So that's just kill you, right? So if it's ketones, what do we do? And if it's I, we're not going to worry about I. If it's L, right, lactate, right? We can do antibiotics, fluids. Okay. LR is preferred because sodium chloride causes metabolic acidosis. The only time you give sodium chloride is someone has metabolic alkalosis. And that's usually the only reason. And they need fluids too, which is almost like a unicorn. All right, and then so we got lactate, and then we got U for uremia, right? Renal failure. renal failure. That means they might be hyper K, right? So yeah, renal failure can do dialysis, but acutely we got the hyper K cocktail, right? And hopefully we can fix the underlying cause of the renal failure. And if it's acute renal failure, that is message 3. That is not message 1. Message 1 is chronic kidney disease. This is all about chronic diseases in this course. Diabetes, CHF. It's a very, what's the word? Not deleterious. What's what I'm looking for? Depressing course, because it's A, because it's hard, but B, because these are all chronic diseases that everybody dies from, and everybody has them, and they linger and they cause all these complications, and a lot of them are irreversible. All right, once they have diagnosed, that's it, done. There's very, very, very narrow opportunity to reverse it. Like CHF, can't reverse it. You're done. You got CHF. This is your trajectory. 5 years, you're probably gonna die. All right, it's a cancer diagnosis. All right, a lot of these things. Okay, so on that happy note, what else do you want to go over?
Do you have the questions by chance? The ones that we didn't during
Questions? What kind of questions?
through the tutorial session, or like you gave to the, I forgot her name. Yeah, because there were some questions like we're all agreeing on, but then when we look back, that you gave her in the chat, like the answer was different. Mike's there, he could probably help me out.
ABGs, lines, and EKGs.
Those are.
Where we at here? It's 2 over. All right. So again, the goal is that you give the rationale for each one. Anytime you're doing an NCLEX book or any kind of questions, you want to know the rationale, because this might be the answer now, and you can't just memorize this answer. You have to know, well, what if one of the things will change, just like with the ABGs. If one little number changes, that changes the whole story, right? So again, don't just say B, 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 right? So you give me the actual rationale. It's B because X, Y, and Z, right? All right, don't be cavemen, please. All right, so number 1, what is this? Do you want to walk through it, or do you want to answer first? What do you want to do? All right, so what is that EKG?
Sinus tach.
That's sinus tach, right? That's a fast rhythm, right? Whoops. So you got 300, 150. It's definitely more than 100, right? It's closer to 150. So we got sinus tach there. So then what does that mean?
It's an SNS response to the lactose.
There's the rhythm above. So why is it not A? So if you're writing along, you can put down this is bradycardia, right? Now, if it was low mag, does that cause tachycardia? Not really. That'd be more torsades. Yes. I pressed this is next to the answer. What is it? If this is bradycardia, you can do it after. That's usually how NCLEX books do it, or you can do it before. Oh, it's called practice questions in the exam 1 study tools. Everybody found it? Nayeli found it. So she was first. Yeah. Hey, refresh. All right, so glucose 189, right? And you said bradycardia, and so hypermagnesemia causes bradycardia. So if you have a good NCLEX book, it gives you rationales for each answers. I hate NCLEX books that have little whole paragraphs. I have no time for this. Please bullet point this. All right, that's why my lecture slides are in bullet points, not like essays. Right? I'm not a reader either. Go ahead. hypoglycemia, not hyperglycemia, right? Or sorry, hypoglycemia, not normoglycemia. So, but 189 is hyperglycemia. Not really. That's not crazy high. Now, usually in the hospital setting, as long as less than 200, they're okay with that, right? So, this is hyperglycemia is more profound. It's not the best answer. It's not the most correct answer, right? It's the worst thing that you can hear professors say, right? But if you have a patient at B that's in a, what is it? Is patient B has a blood sugar 189, patient C has a lactate of 19, and they're barely alive, and they are breathing super fast and they're tachycardic, which patient would you see? That's why it's not the most correct answer, right? Think of a real life scenario. A lactate 16 is ridiculous, right? So normal lactate is 2, right? This is high. This is deadly. Okay. And then PCO2 of 44. That's normal, but if high, right, would cause acidosis and trigger SNS, causing rhythm. Not this time. So in the test, it might say lactate of 1.6 and CO2 of what? Of 64. That would be the right answer then, right? Or it could say blood sugar of 29 and lactate of 1.6. All right, this is why it's important to do the rationales. That way you can dissect it and know that a low blood sugar cause it. So it would be more profound, right? Would be more profound. You can say hyperglycemia greater than 200 would be concerning to cause tachycardia, right? And then hypoglycemia also does. That's less than what? 70. So we're making an NCLEX book right now. All right. So yeah, so you want to be able to dissect these things. And then what I did when I studied nursing school is I just, after lectures, straight to the NCLEX books. And I just made tables and everything out of the NCLEX books. Then I went back to lecture and added to it. And I had like some contradictions, like, well, this says lactate elevated, and that one said lactate decreased, or let's say glucose is more debatable. And where I might say, well, you said high glucose is 180, and this one said 250. So I would make sure that it lines up. But if you have any questions about labs or numbers, I usually gave you that, right? So like for insulin peaks and durations, every single book ever is gonna have a different peak and duration. All right, so just use the one I gave you. Okay. I was gonna say something else about that, but anyways, that's that one. Okay, number 2, same question. So this is talking about knowledge base and critical thinking questions. This is going to be an example question on the test. You got to analyze this rhythm, know what that is. If you say that sinus bradycardia, you're in trouble, right? But not really. Lactate 16, yeah, if it's severe enough, can lead to that. But I didn't really get to that. But yeah, so you got to be able to interpret the rhythm first, right? That's a critical thinking level question where you have an evaluation of the data before you, and you have to know, you have to come to the table with knowledge, right? You can't just memorize MAG 2.7, MAG 2.1, MAG 1.8. You have to memorize that, you have to understand that MAG 2.7 is high, and high MAG causes bradycardia, right? And you can say, well, what if it was low MAG? Well, low MAG doesn't cause, that causes torsades, it might cause some ectopy, right? So then I would make my tables, my study tables just out of these NCLEX questions. I'd say, okay, I would say, lactate is, what I first do is just take notes. I would say lactate 16 causes this, and I convert the notes then into tables later. All right. And then same question is a knowledge-based question, right? So it's exactly the same, right? The euglycemia probably changes to 179, 77, all right? So euglycemia is normal, right? These are the same thing. Severe infection is lactate at 16. So that's a knowledge-based question where I tell you that, SNS response is going to be due to, it could be infection, right? It could be hyperglycemia, hypoglycemia. But, again, your patients don't present and say, I'm feeling hypoglycemic right now, please check my blood sugar, right? They might. That's actually a bad example. I'm feeling my lactate is elevated. Go ahead and check my lactate level. Okay. Yeah, hypoglycemia, they're pretty good about it, actually. Anyways, we got this guy. What is this? That's VTAC, right? We got VTAC there. We got a little some AV dissociation, little P waves built in there. Those guys, little P wave on the downstroke. That's some AV dissociation. That's to seal the deal. But that is VTAC. You got to recognize lethal rhythms. End of story, right? Because as a nurse that gets a license, right, from a state that that you didn't buy from, then you have to be able to recognize that is a VTAC. That's bad. All right. And because that's bad, I know VTAC, there's a little bit of a little asterisk attached to it, right? Because VTAC can have a pulse, right? But first thing I'm going to think about is, well, do they have a pulse? What's my patient look like? Right? So what's the question say? So you have no pulse, right? No pulse means what? Means CAB, right? And CAB means CPR, right? So I'm just going to zero in on that, CPR. That's the right answer, right? And then, CPR is priority, right? If pulse, this wouldn't be right. What would be right? Adenosine? Nope. That's for tachycardias, but which tachycardia? Okay. So it could say it could have an EKG of PSVT. You have to recognize that and say which one of these medications would you do. It could be the exact same prompt, right? With a pulse. But what if it said the exact same, it had SVT and they had no pulse? What are you going to do then? Same thing, right? That's called what? CAB is the intervention, but what's that called when you have PSVT but no pulse? That's pulseless electrical SVT activity, right? So yeah, so that's PSVT. So you got to make sure that's why we do the rationales here. This is for PSVT, and PSVT with, if you have a good NCLEX book, it's going to give you all the stuff. Greater than 90, because it was less than 90. Nope, not doing adenosine, right? What do we do with in that case? We do synchronized cardioversion, right? And for this VTAC, when would synchronize? Because C would be incorrect when. How would we change the stem? They had a pulse, right? This would be for VTAC. Rhythm above VTAC, right? With a pulse. Okay. And even then, it's usually for, we might even trial amiodarone. So we could say with a pulse and what? Right? Amiodarone might be tried. And that's with a pulse, right? We don't mess around, if there's no pulse, we don't mess around. Why is it not, the autocorrect went away? Amiodarone. All right. So then last one, TCP. When do you do TCP? This is for bradycardia. SBP less than 90 or symptomatic, right? What is symptomatic? Hypotension, right? And it could be any one of those things, right? Guaranteed static question on that. So it's not going to just say chest pain. What's another word for chest pain? Palpitations is just fast heart rates. Like some discomfort in their chest, in their pectoral region, or they have a shortness of breath. What's another word for how do you know what shortness of breath is? They got dyspnea, they got orthopnea, they got tachypnea, they got pulse ox less than what? 88, they got a PO2 less than 80. They got circumoral cyanosis. They got restlessness and the pulse ox is low. They have, they are cyanotic. Right? That's a sign of hypoxia, right? Or it just says hypoxic, right? Because that's also another word for shortness of breath, right? And then like confusion, right? There's 12 different ways to describe confusion. There are ANO times 3, times 2, times 1. When you say times 2, that could be person, place, person, time, place, and situation, person, situation, place, time, situation. It could be all the above. There's so many permutations, right? That's 4 factorial, whatever that is. Okay. So then going on. Do you keep going? Keep wanting to go? Okay. Your administered diltiazem, which EKG interval would be concerning? Don't be C for cavemen. Why is A wrong? Would never be worried about this. unless maybe hyper K, and we would see other things first. Yeah. All right, R 0.40. No, that's the interval I gave you. So this is what? This is what? What is that a heart rate of? Yeah, there's a heart rate of 150. When would you be concerned? What's the R to R interval? Good. All right, so PR interval. Does everybody know why that is? How do you calculate a rate on a patient that has a regular rate? It's 60 divided by the R to R, right? And that's how you get a 60 divided by R to R. All right, PR 0.24. All right, that's a prolonged. And BCD drugs prolong PR. Should be held for PR interval greater than 0.20, right? And then it might not be diltiazem, so please don't memorize diltiazem, right? It could be verapamil. It's the same question, right? It could be metoprolol, carvedilol. It doesn't need to be Manbabe because Manbabe are specifically given for arrhythmias. They could be on labetalol for blood pressure, and I would still hold the labetalol because I know it's a beta-1 agonist, a beta-1 blocker that's going to reduce my heart rate, right? So I would hold it for that situation. Okay, QT. Why am I concerned about QTs? Only concerned about this with what antiarrhythmic? Amiodarone, antipsychotics, right? Antiemetics, antibiotics, right? That's what I'm concerned about that, right? So the question could easily be, what is their patients getting, levofloxacin, or patients getting haloperidol, patient is getting temazepam, patient is getting what else? What else is an antiemetic that you give for diabetics who have gastroparesis? Metoclopramide, right? All right. If you have to spell it out there, you can. All right. And what's the next one? That's VTAC, right?
Where did Kelsey go?
She went to look for a bed.
All right. So what does that entail? Patient complains of palpitations, right? Palpitations are always just tachycardia, right? And notices the EKG above. You enter a room and notice patient is a bit diaphoretic and trying to get out of bed. This is the one I gave you. All right. I changed this answer right here because it was dubious. All right. So when would you perform a carotid massage? This would be for S VTAC, okay? With a pulse, obviously, right? But with a good blood pressure. Because there was a good blood pressure, what would we do for SVT? If we did not have a good blood pressure is less than 90, what would we do for SVT? We do cardioversion. It's end of story. No carotid maneuvers, no Sancho, no nothing. Okay, not Sancho, Pancho. You can have Sancho, I guess. Maybe that could happen because of Sancho. All right, so you got to check the blood pressure. All right, is that good? They got enter a room, notice patient, bit diaphoretic, and there's a static question, right? That sounds appropriate, right? And why do you want to check a blood pressure?
Because you would need to know whether you can stay and play or load and go. So
Decide if what? Shock or meds, right? Because meds lower blood pressure. All right, such as which meds? Amio is what we can give for ventricular rhythms. I didn't give you lidocaine, but that's another one that you can use. Lidocaine is the alternative if you have a prolonged QT. All right, so you just put it there for funsies. All right, so yeah, you got ABCs, right? To check a blood pressure, right? We saw already, they're trying to get out of bed, so they probably have a blood pressure. They're moving stuff. But when I see maybe the blood pressure when your blood pressure is low, right? You get confused, right? All right, number C, instruct patient how to blow through a syringe. That's for S for T. Okay, and then I want to be complete, right? You do Valsalva maneuvers, or we do vagal maneuvers, which includes your what? Syringe, right? Valsalva, which is, BM mode. Okay, and we can do what else? We can do the tip over, right? They can do the ice bucket challenge. Okay, they can do a DRE. What's DRE? Digital rectal exam. Yep. So a lot of people in the audience just became conductors just now. All right, so give ordered amiodarone if indicated. When is it indicated? Yeah, the blood pressure is good. We can give amiodarone, right? So give amiodarone. So yes, and indicated means BP greater than 90, right? And then prepare for unsynchronized cardioversion. No, why?
Yes.
Before patient without a pulse. If this patient had a pulse, what did it do, right? Have a what instead? A synchronized cardioversion, right? Yes. It's an R wave detection. There's R waves there, right? It's the big stuff. It's the big points, the points of the R waves. All right, technically those are S waves, but it'll do that. It'll detect it.
I wouldn't want to put this patient like on pads right away because of their condition. Wouldn't that be preparing for a cardioversion if necessary?
For unsynchronized, I think we're looking a little bit into it. It's like, yeah, I would, I would prepare for cardioversion, but synchronized or unsynchronized, yes. If it said place pads on patients, yeah, that's appropriate, right? Because they might be getting sick, right? Yeah, we're not preparing for unsynchronized, right? For the whole statement, we're not preparing for it to do unsynchronized. Yeah, if they lost
Gotcha,
a pulse,
okay.
but then we're adding information into it, right? They'd have to say they had no pulse. Then yes, I prepare for unsynchronized cardioversion. Well, someone did CPR, someone got the epi ready, someone got was doing CPR and everything. Okay, all right, you want to keep going? We only got like 20-ish minutes or so. I mean, I can be here all day, but I was told that some people want to get the peripheral IV action on. All right, what else we got? What's this? I think we did this already in the trap, but what is that? PSVT, right? Usually if a heart rate is greater than 150, we're thinking PSVT, okay? There are certain criteria for it, but we definitely got a fast rate. So how do we fix that? Because PSVT only has one drug associated with it. What is that? Adenosine, right? So amiodarone could be given, right? For atrial ventricular. But PSVT is treated by one drug and one drug only. Yes.
So theoretically, give the adenosine to see the underlying rhythm, and then if it wasn't actually PSVT and they were like an AFib RVR, then you would give the amiodarone.
So the question is, if you do, why wouldn't you just try something else, right? But the priorities, right, are ABCs, right? So airway, breathing, circulation, check a blood pressure, and then we're not considering medications at that point usually, right? But we have a good blood pressure, and we could do some, and then we can do, we're probably gonna tell them anyways, as we go call the doctor and stuff. We say go ahead and bear down and do this, and we're gonna tip you over, blow through the syringe. But we're gonna get a 12 lead. That's part of our operationalized, or how we do this operation, right? We're gonna raise the head of the bed as long as the blood pressure is good. And we can then throw them on some oxygen, right? As long as the stats are low. And then we can go ahead and get a 12 lead, and the 12 lead is going to, hopefully we can interpret that as PSVT. All right, so just assume that this is, I mean, that we're getting a 12 lead and we've got PSVT going. Okay, so the other piece of that was, what was I going to say about that? I forgot. There it is. So yeah, so adenosine, all right? So adenosine is given for, so it's to yes, right? But we don't have a blood pressure here, but we assume that that's what we're going to be doing. It says it had this EKG, we're going to be giving adenosine, right? So one disease drug, right? The question was also like, why not give it to give adenosine to everybody and just say, well, because I know it's one of our ABCD drugs, because adenosine restarts the heart, right? And SVT is circuits that are going haywire, right? Not like ectopic sites like AFib, A-flutter, and VTAC, right? It is just a re-entrant circuit that's getting out of control, that we need to restart it so to get everything back online. Okay, C, why not atropine? For bradycardias that are symptomatic, right? And then, so this could easily be a question, has a bradycardia up there, right? Has a first degree block with a rate of 32, right? Or it has a, you know, has a PAC, has a like a sinus brady of 20 with a couple PACs in it, right? You have atropine in that case. And atenolol, that's a man babe, right? So that's good, right? This is indicated for atrial rhythms, right? But PSVT has one treatment and one treatment only. So the best drug is the PSVT. It's not the best drug as like prescribing. It's like that drug is the one that works, right? It's like it wouldn't throw an SGLT2 inhibitor at that, even though it's super hot, right? It's like that's the drug associated with that disease process. All right, next one. What is that? We did that one in the chat, right? They got a PAC. This really probably might be a little faster rhythm, but either way, we know PACs are caused by right? So yes, PACs are caused by low lights, right? PICC line and right atrium. Yes, this is a complication. All right, calcium, 12.6. Is that a low light? It's a highlight. So that I would highlight. It would be, I mean, I would probably make this a little more tachyrhythmic, a little more maybe normal, because you could argue that this is bradycardia, 1, 2, 3, 4, 5 complexes, a heart rate of 50, and hypercalcemia causes that, right? So we're gonna fix that real quick. Dig level. Well, that wouldn't be accurate. Let's put K of 6.6, right? Well, that's even wrong also. Let's do 4.9, right? Anyways, we'll just keep it for now. And I'll probably put a faster one, right? Let's just make it 11. All right, so hypercalcemia can cause bradyarrhythmias, but usually greater than 15. It's like really high. It's like a K of 5.2 is not going to cause bradycardia. A K of 7.2 would. Because there's a lot of nuance. Like it can't be, it's not black and white, unfortunately, on these things. It's a lot of nuance. Like there's a spectrum, right? Like with hypoglycemia and hypoxia, they all get SNS symptoms until the hypoxia and hypoglycemia is enough that the ANS medulla can't function anymore. And now you have no SNS, you get bradycardias. All right, so MAG 1.4. We just mentioned above that, yeah, or MAG 1.4 causes ectopy, yeah. Including MAG, calcium, and K, right? Cause ectopy, which is PACs and PVCs. And what's the difference between a PAC and a PVC? Where it comes from, which is where does it come from? The atria or the ventricles. And how do you know it came from the atria? 100% it came from the atria is when it's what? When it's narrow, right? If it came from the ventricles, yes, there's a little asterisk where it could be atrial, but it's usually ventricular if it's wide. Okay. So sodium 108. When I said low lights, seven. What is that? Patient is taking digoxin. Which of the following reasons would you notify the MD? Because you got a dig to give and you're like, nope, I got a license.
The calcium.
So you got hypercalcemia, right? Now, if you don't understand the mechanism, what we discussed in the lecture, that's fine, as long as you memorize it, right? We're trying to give you the mechanism, you get to it every time. All right, so hypercalcemia does it, and what else? That's the only one that's high. The other ones are low, right? Hypercalcemia causes dig toxicity because, and you can fill in the blanks there. You want to aim for rationales. You want to get the rationales behind all these things. If you don't, don't try to memorize. And it's a little bit too late right now to do that. So after Monday's lecture or after each lecture, that's what you want to be doing. You want to be trying to get rationales behind all the things. All right, so then K of 5.9. Low K causes dig toxicity, not high. Okay. Yeah, K of 5.9 can cause bradycardia, or maybe they get in there. Usually when more than 6.5 cause bradycardias. And then MAG of 3.2. So low MAG can cause low K, and that would be concerning. All right, not high MAG. All right, so the question easily could be a MAG of what would be low? Yeah, 0.8 or so. Yeah, and really on tele and ICU, it's more than 1.8. So usually we like all of our mags more than 2. So when it says, like you said, what 1.2 is normal, we would freak out. We would ship our drawers. All right. D.
Yes, notify them.
Yes. What is this?
The 3rd degree block.
A 3rd degree block. Dig isn't going to work anyways, you could argue. So I could still give it. It's not going to do anything, but maybe the dig caused a 3rd degree block, right? And that's definitely concerning. I would let somebody know.
Will the dig slow it down enough to make that like VTAC at some point?
It could be, they could be dig toxic, and they could be presenting like this. All right, it's an E. This is what?
Tachycardia.
All right, number, whatever this is, 8, I guess. Okay, what is that? Those are peak T waves, right? You can take that home to the bank. Those are peak T waves, right? It might even, the monitor text or the EKG monitor might even read these as R waves and say your rhythm is double what it is. Okay, so what causes hyperkalemia? Or medication to administer, sorry, it's asking how to fix it, right? So do you give atenolol? You thought this was a beta blocker, beta agonist. It is a beta blocker, right? OL are agonists and LOL are blockers, right? So what's the medication you give for hyperkalemia? Beta agonists or beta blockers? Beta agonists, right? Albuterol, there it is. And then calcium. Like, the heart rate is what? 300, 150, more than 100, right?
It's rare, but you would, I guess.
Would you give calcium? Yes, right? Calcium is indicated for hyperkalemia. Right? And in this case, I probably give calcium gluconate because it doesn't look super crazy, right? But if they gave me a patient situation where they're feeling really woozy and they got an ABG, it looks horrible, yeah, I would definitely hit them up with some calcium. And if I had like a bradycardia, definitely get calcium chloride instead of calcium gluconate, because which one's stronger? The chloride, right? This
Correct.
didn't specify, but yes, we give calcium. What about calcitonin? Haven't heard of that, right? But the calcitonin is to tone down calcium. That lowers calcium levels in like, yep, we give it, sometimes it's going to be give like hyperparathyroidism and kidney failure and such. But yeah, that's for patients that have high calcium levels. We give calcitonin. All right, this lowers calcium and endocrine, or CKD, etc. Not for hyper K. And insulin, we give insulin,
Yes.
but they don't have a blood sugar. Should I give it?
Ah,
And now you're looking too far into it, right? It's like, but there was, there was no blood sugar. Don't I check a blood sugar first? We're assuming that it's these medications are safe to give, right? This is a hyper K situation. Of course, we would check a blood sugar, but which is medication would you give? You give insulin, right? Right? Insulin lowers K. Yeah. So incretin, do you give that? That's not a thing. You don't like pull up a bottle of incretin. We have medications that promote the the incretin in the body, right? Which ones are those?
GLP and DP4.
Mm-hmm. This isn't a drug. Okay, we have PO meds, DP4 inhibitors, and GLPs. All right, and number 9, tachycardia, tachypnea, diaphoresis. They have a PICC line. What would you expect?
Metabolic acidosis.
They have an infection, right? They got a history of PICC line, and they're really sick right now. I mean, it could be another illness that's causing it, but we're giving you some red flags here. I'd probably give you something like they have like purulent output or something. I should have asked you, what are signs of collapsy? Purulent output, right? It's not pussy because that doesn't look good on paper. You have a purulent pussy, febrile, right? Reddening, right? So that's a sign that they have a collapsy, right? And collapses put you at risk for what ABG disorder?
Metabolic acidosis.
Acidosis, right? Infection is a cause of Met A, and this is a collapsy, maybe. All right, I have to give you more information. Metabolic alkalosis, no, that's not what's going on here, right? Tachypnea, yeah, that could cause respiratory what? Right, respiratory acidosis, that's would be failed respiratory alkalosis. But you can see here, these 2 questions are exactly the same, right? Exactly the same. The answer is just substituted, right? So one is where you just have to, recognize it because you studied it or because you memorized it. And one is where you have to understand. This is, which one of these is metabolic acidosis? It's in the same order, so spoiler. But you'd have to recognize that, oh, that's metabolic acidosis. This would be it'd be the ABG I'd expect. And I'd be concerned for, especially if you have a PICC line with purulent output and I have all these symptoms, I would be concerned with this ABG. Okay, so which one is it again? So this is metabolic acidosis, right? Same rationale as above. This is metabolic alkalosis, right? Etc. All right, number 10. Seven, 3, 4. Not really. Maybe if resolved. Blood glucose of 194.
Not DK.
Maybe, right? Maybe, right? Usually blood glucose greater than 250. Sodium 172. No, they have hyponatremia. Now, if it says sodium of what would be hyponatremia?
100.
Would be less than 135 is hyponatremia, right? All right, but yeah, 120, 112, 128, right? That is concerning for hyponatremia. And if we see someone has DKA, like we're not going to freak out about it. We know that's just that goes along with it. Okay, so this could be a SATA question, for instance, right? Have hyponatremia, and then, or I could say the anion gap is 10, right, or 12. And then only the hyponatremia was the odd one, right? Or the pH is 7 point what would be DK. Yeah.
7.14.
Yeah, less than 730, basically. Okay. Because that's the difference between HS and DK is the 30 part. All right, so anion gap of 24, yes, right? And I got greater than 12 indicates metabolic acidosis, which DK could cause. Okay. All right, that makes sense. So collapse prevention, extraluminal, right? Static question. So that means not the lumen and the tubing and management of the tubing, but management of everything else. So washing hands, always usually the right answer. It'd be hard to say, no, not going to wash my hands today, right? Washing hands, always the right answer. In a SATA, right? Maybe there's a better answer in the other one, but usually we wouldn't put you between washing hands because that'll just disturb the nursing gods. All right, swab caps and open ports. That's intraluminal, right? White port 5 seconds before accessing. This is intraluminal and should be greater than 15 seconds, right? So this question could easily be asking intraluminal, and then B and C would be right? Or actually B would only be right because C is 5 seconds. That'd be incorrect, right? So it's like true, false, plus, right? So that's true, but not really true. And then D, change dressing PRN. Yes, right? And when do you do it? PRN soiled, right? Peeling, blood, right? Oozing, right? These are the times, right? If covered, then Q2 days, otherwise Q7 days, right? IV tubing every 7 days. This is intraluminal and should be what?
96 mLs.
96 hours. Okay. So that's, so you can see how this could be a different question. It could say intraluminal, and then which one would be right if it said intraluminal? B only, right? But if we change this to 15 seconds, then it'd be B and C. If we change this to Q72 hours, that would be BCE, right? So doing the rationales will help you identify the other potential questions out there, because you can only ask you so many questions, right? Patients had a central line for 10 days. Complications? Would they have ectopy?
It's possible, but they've had it for 10 days. So
You can have some ectopy, but usually we're expecting tachycardias, right? Can be caused of acidosis, but is there something better? Because this is not a SATA, right? Sudden dyspnea.
yes,
Yeah, this is a pneumothorax, right? Or PE maybe, and PE is not a cause of, well, it can be cause of line if it's like midline or something, or for a long day, but 10 days, it's going to be hard pressed to develop one that amount of time, right? And acute complication, not 10 days. All right, localized erythema. That looks sus, right? So that is what? Infection, right? Inflammation. And can also include what? Because it might not just say erythema, it could be what? Purulent, right? Right? It could be excoriated, it could be all kinds of other things, right? And then extravasation and ulceration. Central lines are given to avoid that, right? This occurs with peripheral lines, not central, right? And this is a sign of extravasation, but right. So it could easily say a patient has a peripheral line and they're getting this medication, right? What could be a symptom? Not pneumothorax, that doesn't have a peripheral IV, right? All right, 2 more, all right? Complication of a subclavian line removal. So placing Trendelenburg, complication of No, that's not a great response, but you know, this is to prevent, right? And we would avoid high Fowlers, and we would avoid other things, right? Air embolus, is that a complication of subclavian line removal? Yes. Air can enter if blood gravity not down with Trendelenburg. All right, pulmonary embolus, is that a complication of subclavian line removal? So what is trying to make you differentiate is it a air embolus or pulmonary embolus? Is pulmonary embolus a cause or a complication? No, it's not. All right, so a PE can come from, usually comes from an extremity, or maybe a pelvis, or maybe an ankle, right? Which is not usually where you have your lines, right? Yes, if it's like in a PIC line or midline, they can form a clot there, but that's not a subclavian site, right? No. The only lines.
This one's like, if you change the question to a complication of femoral.
Femoral is not really, is not high on the risk. Yes, that's in the pelvic area, but it's not like in the pelvic. That's more with your your pregnant ladies have the pelvic clots and such. This would be a PIC or midline. Okay, and not on removal. So look at the key word here. It's on removal, right? Even when you pull out a PIC line, you don't get clots. Okay, hematoma formation, is that a complication? Yes. All right, we must hold pressure for how long? 5 minutes, right? 5 to 10 minutes, right? 10 minutes, 10 plus minutes, I should say. For what? Femoral, right? So this could say femoral line insertion, right? And hematoma is still accurate. If it's a femoral line, are you at risk for air embolus? Negative, no, all right? And purulent drainage, is that a complication of removal? No, this is due to collapsing, right? Not removal. All right, last one. Patient taking glipizide, what's the side effect? What is glipizide? Sulfonylurea, and sulfonylureas do what? They're for diabetics, right? And they GM motility, it doesn't really affect that. Sulfonylurea, you might think of GLP-1. Sulfonylureas are going to promote insulin secretion. They make it very, very easy to release insulin, right? So you have severe risk of hypoglycemia, right? Also, they can cause what?
Lactic acidosis.
That's your metformin cause lactic acidosis. They cause weight gain, and what's life-threatening? A major adverse cardiovascular event. They cause MACE, right? That's the only one of your diabetic meds that cause MACE. So there could be a question that says, hey, they're on this medication, sulfonylurea or meglitidine, right? And they have this lethal rhythm. What lethal rhythm would you expect, right? What would you expect? Like VTAC, VFib, right? asystole, PEA, right? They have no pulse and they were on meglitidine, right? Or they have no pulse and they're on glyburide, or no pulse and they're on glipizide, right? So that could be because of MACE. So this side effect is looking at what? What's stocking and glove paresthesia? This is due to hyperglycemia complications and DM, not hypoglycemia, which is a risk of sulfonylureas, right? Tachycardia diaphoresis and altered. That's hypoglycemia, right? So on the table, on the PowerPoint, or on the drug guide, it says they're at risk for hypoglycemia, right? But do you know what hypoglycemia means? So this is a question that's more, evaluation levels. Like I'm evaluating these symptoms. These symptoms to me look like diaphoresis, look like hypoglycemia, right? So this is hypoglycemia. These are symptoms of hypoglycemia. Which SUs cause. Tachycardia, warm to touch, abdominal pain. That's DKA. Hyperglycemia, right? Emesis, sensation of feeling full. That's just gastroparesis, right? A chronic complication from hyperglycemia, right? When I make this a SATA, we can put down, they have a lethal rhythm here, right? Which one is lethal? Tell me stop, like Olive Garden. Oh. Right. So this is what? A lethal rhythm. Vascular. Some would say major MACE, right? So if this was a SATA, which ones are correct? E and B. Okay. All right, any other last minute questions? I could go for another 2 hours, but I want to make sure you have a healthy mind too. All right. Does it sound more achievable, or sound like more now you're more scared? Okay. So conquering the materials is the first hurdle, and then the second hurdle is understand the material. And unfortunately, the test is on understanding. Right. If it was just on the material, it would be any other class at this college, right? Where you have to look at the material and regurgitate it on the test. Right. But that's not going to help you take care of patients and be safe patient provider. Mm-hmm. Mm-hmm. EKGs, yeah. So that's more advanced. That's just something that can happen. You can see a little scooped ST segment on digitoxicity.
I don't know if I cut it, but it looked like it.
So this one,
Yeah.
it's just a wide QRS. I mean, you could argue that, but yeah. So yeah, it's a wide QRS. Mm-hmm.
Because I just know good.
Yeah, and that even if you had that would help you with the right answer too. Okay. All right. Any other questions in Zoom?
I'm good. Thank you.
All right.